So Dr. Koratala is an associate professor of medicine at Medical College of Wisconsin. He's actually a former fellow of our program. He graduated in 2016, and we're very proud of him. Obviously, he picked up point-of-care ultrasound soon after he graduated and was still at the University of Florida, and then continued to climb up the ladder. He has gone to the highest possible level, I think, in academia. He's now an established expert in POCUS. It's difficult these days to talk about POCUS or have some kind of a POCUS program somewhere without his name being somewhere, especially he's an expert in the nephrology-oriented POCUS. His Twitter handle and his nickname actually for us is NephroPOCUS. He's invited around the world. He gives talks, presentations, workshops, weblogs, everything, webinars. I almost hesitate to call him or text him most of the times because I don't know in which time zone I might find him. Just 2 weeks ago, we had some email exchanges with him, and then I realized that he was in Hawaii in CHEST conference. As you all know, we will have American Society of Nephrology annual meeting next week in Philadelphia. He'll be one of the speakers, obviously. So until this morning, actually, Dr. Koratala didn't know that he will be presenting today. It just shows us his academic caliber to be always prepared and be able to present with just a couple of hour notice. I don't know if I see him here. Abhilash, thank you very much for accepting our invitation in such a short notice. It's always nice to see you back here at UF, even if it is virtual. The stage is yours.
Thank you, Dr. Kazuri. Thanks so much for inviting me, and it's always a pleasure to be there. It's both ways, and it's always a pleasure to talk to my teachers and mentors. For the applicants, I endorse this program 100%, not because Dr. Kazuri asked me to do, but I wholeheartedly do it. So without further delay, let me share my screen. Okay, are you able to see my full screen?
Yes, the way we should.
It's not presenter mode, right?
No, it's the right way.
Perfect. Thank you. Okay, so in this brief lecture, I'll provide an overview of point-of-care ultrasonography use in cirrhosis-associated acute kidney injury. And I have no relationships with ineligible companies. First, let's start by recollecting the causes of acute kidney injury in cirrhosis, because there are a lot of causes and it's very hard to pinpoint on hepatorenal syndrome versus not. So in clinical practice, we tend to rely so much on clinical judgment and empiric treatment. So when somebody has portal hypertension because of the stiff liver, there is a lot of vasoactive substances rising in the blood. So there are vasodilators like nitric oxide leading to splanchnic vasodilation and reduced systemic vascular resistance. And because of that, there is a high output cardiac state. So whenever there is vasodilation, the heart has to pump harder, eventually accumulate more volume, and the cardiac output is pretty high. And that could be a high output cardiac state when just the cardiac output is increased, or it could be high output cardiac failure, because when the heart is overworking like that, the backward pressures increase, leading to pulmonary edema or elevated right atrial pressure. That state is called failure. And going back to the kidney, there is an activation of renin-angiotensin-aldosterone system, and there is intense renal vasoconstriction and decreased renal blood flow. In addition, you have release of bilirubin and inflammatory cytokines, which lead to renal tubular injury. You call it cholemic nephropathy or bile cast nephropathy. And also you have bacterial translocation and cytokine release and systemic inflammation, which in turn affect the renal blood flow as well as have a direct impact on the renal tubular cells. And these patients typically take lactulose, or they can have infections and diarrhea, which can lead to volume depletion and subsequently decreased renal blood flow. And also they very commonly have ascites, and as you know, tense ascites can lead to increased intra-abdominal pressure, and increased intra-abdominal pressure compromises renal blood flow. And in late stages of cirrhosis-related cardiac changes, you can have decreased cardiac output leading to cirrhotic cardiomyopathy, which Dr. Kazori calls hepatocardiorenal syndrome, and which leads to elevated right atrial pressure, and elevated right atrial pressure leads to systemic venous congestion, which results in congestive nephropathy because renal perfusion is dependent on both forward flow, which is mean arterial pressure, as well as the backward pressure, which is the right atrial pressure. And you can have other etiologies of acute kidney injury, as in these patients are getting a lot of antibiotics. They may have infections causing acute interstitial nephritis. Or you can also have glomerulonephritis in coexisting with cirrhosis. You can have IgA nephropathy more commonly, or membranoproliferative glomerulonephritis, cryoglobulinemia, and so on. So basically the point is there are a lot of diagnostic considerations when evaluating a patient with cirrhosis and acute kidney injury. But we have very limited tools, right? So is urine sodium helpful, which is one of the commonly used parameters? Not so much, because urine sodium is low if the patient has volume depletion. It's low if the patient is congested and has congestive nephropathy because of RAS activation. And in early stages of acute tubular injury, urine sodium is low also. If the patient has intra-abdominal hypertension, urine sodium is low. And if the patient just got a CAT scan with iodinated contrast, that causes renal vasoconstriction also, and that also causes urine low sodium. So you have all these causes of low sodium in addition to hepatorenal syndrome. So hepatorenal syndrome is hard to diagnose just based on low urine sodium alone. So these days we are using low cutoff urine sodium instead of less than 20. The lab might report up to less than 10. That might be partially helpful, but still there are other potential causes. So what is point of care ultrasound? Point of care ultrasound is an ultrasound examination performed at the patient's bedside, that is at the point of care, by the clinician, that is the treating physician, to answer focused questions. And answering these questions at the end of history taking and conventional physical examination will either provide the diagnosis or narrow the differential diagnosis, or you can use point of care ultrasound to perform a bedside procedure like placing a dialysis catheter, or performing a kidney biopsy, or performing a paracentesis in a cirrhotic patient. Over the past several years, POCUS has evolved as a component of physical examination. Insonation, that is POCUS, is now considered fifth pillar of bedside clinical examination, in addition to the conventional 4 pillars of inspection, palpation, percussion, and auscultation. If you think about it, what's physical examination? It's a process of evaluating objective anatomic findings at the bedside and thoughtfully integrating with patient's history and clinical context. And that's what POCUS is letting you do. And POCUS has become an integral component of clinical nephrology. Fellows and prospective fellows are going to most likely read this textbook, Comprehensive Clinical Nephrology. And in the latest edition, we wrote a chapter on point of care ultrasound and multi-organ point of care ultrasound that's not limited to kidney. Okay, so before going into cirrhosis and POCUS, just one slide for people who are not very familiar with reading ultrasound images. So how do different structures appear on grayscale ultrasound? So structures that are excellent reflectors of ultrasound, that means if a structure reflects a lot of sound waves, or in other words, if a structure makes more echoes, that structure is called hyperechoic. And these are bright structures. Examples include bones, stones, and fibrous structures such as diaphragm. And bones and stones typically give some shadowing behind them because they are not allowing any sound waves to pass beyond them. So it's like you're an opaque object and you are standing in front of a light beam, you have a shadow behind you. Same thing with the sound. That's why it's called acoustic shadowing. And I put air in a different color because we are so much used to seeing air as a black structure on CAT scans and X-rays, but air appears white on ultrasound. That's important to remember. Say, for example, one bad thing about it is the bowel is filled with air. So if a structure is overlapped by bowel, it's hard to see anything underneath. And something more ominous is, say you have a patient with kidney infection, and you see some bright structures within the kidney, you can mistake those for stones, while in reality, it could be air leading to emphysematous pyelonephritis. So that's about bright structures or hyperechoic structures. And structures that are excellent transmitters of ultrasound waves, they appear black on ultrasound because they are not making any echoes. They are called anechoic structures. Examples include blood. So, the fresh blood. So all the blood vessels appear black on ultrasound. Heart appears black on ultrasound except for the valves. And urine is black. So hydronephrosis is black. Urinary bladder that is filled with urine is black. Any clear fluid is black. So all cystic structures are anechoic. And rest of the structures appear in different shades of gray because they transmit some ultrasound waves and reflect some. Okay, with that knowledge, say, think about a patient with cirrhosis who has acute kidney injury. And first thing is always kidney ultrasound. You want to exclude obstructive nephropathy. It's overall less common, but if you find it, it's a potentially treatable condition. So that should always be a part of physical examination to perform kidney ultrasound to exclude urinary obstruction. So how does kidney appear on grayscale ultrasound? Here we are looking at the right kidney through the liver. So liver is on top, and this bean-shaped, well-defined structure is the kidney, which is divided into outer cortex and inner medullary pyramids. So cortex is usually less bright or of similar brightness compared to that of liver, this thing here. And the medullary pyramids are usually black. They might not be like very clearly seen, but if you see this here, these black structures are medullary pyramids. And in the middle of the kidney, where normally there is collecting system, if it is not dilated, that means if the patient doesn't have hydronephrosis, you won't see collecting system because it's encased in sinus fat. And that fat is bright. And that's all you see. These are the structures that you see in kidney on ultrasound examination. And usually the size of the kidney, the length of the kidney is about 10 to 12 centimeters. That is the end-to-end measurement. And the cortical thickness is 0.7 to 1.1 centimeters. I roughly remember it as approximately 1 centimeter. And the parenchymal thickness, which encompasses both cortex and medulla, is about 1.5 to 2 centimeters. That means twice as much as of cortex. And as you know, the kidney size decreases in chronic kidney disease. So how does hydronephrosis appear on kidney ultrasound? We said that collecting system in its undilated state is not seen, right? But if you have hydronephrosis, that means there is distal obstruction and the urine is going back into the kidney. So because of the backflow, this urine going into the kidney forms the shape of these major and minor calyces and goes and compresses on the kidney parenchyma. And how much it compresses on the parenchyma depends upon the severity of hydronephrosis. But the point is, hydronephrosis appears as a anechoic, that means black, branching structure going into the kidney. And here is a transverse view of the kidney. In the middle, you see this anechoic branching structure consistent with hydronephrosis. And the cortical echogenicity, this is another common thing we read in radiology reports, that the echogenicity has increased or it's heterogeneous and so on. And a common mistake, especially done by internal medicine residents, and not only residents, but also nephrology fellows, frequently use this term, increased cortical echogenicity, synonymously with chronic kidney disease. But that's not correct. In chronic kidney disease, the cortical echogenicity is increased because of interstitial fibrosis, but it can also increase in any parenchymal disease. So you have a patient with acute glomerulonephritis, lupus nephritis, the cortical echogenicity is increased, or interstitial inflammation as an AIN or even ATN, the cortical echogenicity is increased. So this you cannot use to differentiate between AKI and CKD if you don't know the patient's baseline. However, having said that, if you have increased echogenicity coupled with small kidneys, that is the kidney length less than 9 centimeters, and thin appearing kidneys, that is reduced cortical echogenicity, then it's most likely CKD. So in the context of cirrhosis, this becomes even more trickier and non-specific because most patients have ascites, right? So here in both these images, we are looking at the right kidney. So here is the liver, here is the right kidney. And all this black thing here is ascites, because ascites is fluid. Fluid appears black on ultrasound. So in both these images, all this black area here is ascites. So when you have black area, these things are good transmitters of ultrasound, right? So the ultrasound beam nicely passes through this black structure. That means it has more energy here. So when it has more energy, all this area appears bright or white. So it's like opposite of acoustic shadowing. It's called acoustic enhancement. So because of this enhancement, it's hard to compare the echogenicity of cortex with that of liver, because in fact, both liver and kidney become bright. So you cannot trust cortical echogenicity in cirrhosis, especially when the patients have ascites. How about urinary bladder? Kidney ultrasound or urinary tract ultrasound is never complete without examining the bladder. So bladder, when it's filled with urine, it appears anechoic because urine is fluid. And okay, let's see a case. So a patient with cirrhosis and acute kidney injury is not making any urine. Bedside automated bladder scanner reads 450 cc, but when the nurse put a straight catheter, nothing was coming out. So what's the next best step? Should we call urology? Before that, we have to perform physical examination. And physical examination for nephrology is point of care ultrasound. So we put the transducer just above the pubic symphysis and see this. Yeah, we see relatively well-defined structure, which is fluid filled. So is this urinary bladder? And if this is urinary bladder, why isn't anything coming out? But here there are some hazy things here, right? It doesn't seem to be that well defined, but I don't know. These things could just be some debris within the bladder. But now we rotate the transducer and see the same thing in long axis. Now, when you do that, you can clearly see that this thing is not in continuum, and all these white junky things that are coming into this cavity, these are bowel loops. So this is fluid for sure. That's why bladder scanner is reading 450 cc. But that fluid is not urine. This is nothing but pelvic ascites. So automated bladder scanners cannot differentiate pelvic ascites and urinary bladder. So it's up to you to perform physical examination and tease them out. And also in a case of trauma, or you did some traumatic paracentesis, you can have fresh blood in the peritoneum. That also the bladder scanner cannot distinguish. So this is the anatomy, just in case you didn't quite catch that. So here is the urinary bladder, and here is the uterus in a female, and all this is the peritoneal cavity. So this is what you are seeing when you put the transducer above the pubic symphysis. And sometimes the bladder also has some urine, right? Then you need to orient the probe a little bit lower and look into the pelvis. You might potentially find bladder. And how about this image here? This is also suprapubic scan, but in a female patient with cirrhosis. Does it look familiar? Any Star Wars fans? So this looks like a TIE fighter, right? So this thing in the middle with these things. So what's going on here? So now we look in a different axis. So in the long axis, let's remove this ink. So you see the fluid here, fluid, and in the middle, you see this structure, which is uterus. So in this female patient, this is uterus floating in pelvic ascites. Anyway, so how does urinary bladder with Foley catheter look like? We said the full bladder looks anechoic or black because urine is black. But if you put a Foley catheter, the bladder is drained. So you have a decompressed urinary bladder. You shouldn't be seeing that much black urine there. But here you see a well-defined anechoic structure that corresponds to the balloon of the Foley catheter, because the balloon of the Foley catheter contains fluid. It's like a cyst. So you will see a small, well-defined cystic structure and the bladder compressed over that. So here we have a patient with cirrhosis and in the intensive care unit who has a Foley catheter and not making urine. So what's the problem here? So first you perform physical examination before calling urology or contemplating dialysis. So this is what we see. So you do see this nice round cystic structure corresponding to Foley balloon, but the bladder, instead of being nicely decompressed, it is full. That means the Foley catheter is not doing its job. This is a case of obstructed Foley catheter. So all these things can happen on a day-to-day basis. So simple physical examination, which takes just a couple of minutes, can answer these important questions. So now going to the hemodynamic acute kidney injury. That's where multi-organ POCUS is more helpful. So what are the focused clinical questions that we have in mind when evaluating a patient with possible hemodynamic AKI? And we say hemodynamic AKI instead of pre-renal. It's essentially pre-renal AKI. But what's happening is, like, when you say pre-renal, most of us tend to think about volume depletion and not paying attention to congestive nephropathy. But as you know, anything that compromises kidney perfusion that happens before the kidney is pre-renal kidney injury. It could be congestive heart failure leading to venous congestion and congestive nephropathy, or it could be a vasodilatory state or a cardiogenic shock, anything that compromises perfusion. So now we use the term hemodynamic AKI to better encompass all these things. So what are the clinical questions now? Say, assume this patient is hypotensive, right? Should I give fluid? Should I remove fluid from this patient? Because if you have a lot of fluid in the body, that the right ventricle is filled up and that compresses on the left ventricle, leading to decreased cardiac output. So in that case, removing fluid will actually improve the blood pressure, and giving fluid will actually kill the patient. Or does the cardiac pump need help? So once you answer this initial set of questions, then you have further questions. Am I giving adequate amount of fluid? Am I removing adequate amount of fluid using dialysis, CRRT, or diuretics, whatever? So these are some questions. And in the context of cirrhosis, this management is plagued by empiric albumin administration. That's what guidelines recommend, right? So because most of us don't do POCUS, so because we don't know how to examine a patient, just randomly give albumin, assuming these patients have volume depletion related kidney injury. And more evidence points to hazardous effects of this empiric albumin therapy. For example, in this study, both are NEGM studies. In the first study here, in patients who were hospitalized with decompensated cirrhosis, albumin infusions to target a albumin level of more than or equal to 3 was not more beneficial than standard of care. That's one thing. And albumin group had higher incidence of pulmonary edema. And in a recent trial of terlipressin, comparing it with placebo, these patients also received albumin simultaneously, and respiratory failure was one significant cause of the adverse events in this study. So basically, what's happening in these patients is like this: you're overloading them with albumin, and on top of that, you're giving terlipressin, which increases cardiac afterload, ultimately leading to pulmonary edema and respiratory failure. And remember the first slide, we talked about the causes of AKI in the mechanisms. We said these patients often have high output cardiac failure, and that itself can raise the cardiac filling pressures at baseline, making them more susceptible to developing these ill effects of excess fluid. And there is just one recent study, a single center retrospective study, but an eye opener. So in this study, they had 127 patients with cirrhosis and acute kidney injury who met criteria for hepatorenal syndrome when they were evaluated clinically. And when these patients got right heart catheterization as a part of a transplant workup, what they found was 79 out of 127 patients had elevated pulmonary capillary wedge pressure, and 68 of them had elevated right atrial pressure. So both left and right heart pressures were elevated in more than 60% of these patients, who these people thought, the physicians thought, they had hepatorenal syndrome. And because of the elevated cardiac filling pressures, these people received diuretics. After 3 days, the serum creatinine has decreased from 2 to 1.5. So which is a retrospective evidence of improvement in congestive nephropathy with volume removal. And during fellowship, Dr. Kazori used to always say, just don't say the patient has HRS like randomly as soon as you see the patient, because giving them a diagnosis of HRS is like giving them a diagnosis which is worse than pancreatic cancer in terms of prognosis. So be mindful of that. Okay, so how does bedside hemodynamic assessment look like with point of care ultrasound? So we evaluate the whole hemodynamic circuit. Hemodynamic assessment is not just single organ ultrasound, IVC or just lung. So you want to look at how the heart is working, the cardiac pump function, and if you are able to evaluate, you should evaluate the stroke volume, and we'll get to that why we should do all these things. And then you evaluate the back pressures of the heart. If the left heart pressure is elevated, you have increased extravascular lung water. You perform lung ultrasound and get that information without radiation. And if the right heart pressure is elevated, that leads to systemic venous congestion and subsequent congestive organ injury. So you can do IVC ultrasound and other advanced Doppler measurements to evaluate that. So basically evaluate the whole hemodynamic circuit. So let's go back to this case of cirrhosis. Here we have a young patient. This is a real case. Young patient with cirrhosis who was seen for acute kidney injury. He has been getting the standard HRS cocktail. That's what we call, right? So albumin, octreotide, midodrine, without assessing any, getting any objective evidence for fluid status. And usually young patients tolerate fluid overload, right? So they might not develop edema that easily. And as you know, edema is generally not so sensitive to detect fluid overload and even auscultation. And we know how good our auscultation skills are. Anyway, so we performed physical examination in this patient. That means we performed sono auscultation or lung ultrasound. And this is what we saw. So we see, these are representative images of lung ultrasound from this patient. So we see this bright line, a horizontal line followed by these vertical sun ray like looking lung. So what does it mean? So what does how does a normal lung ultrasound look like? Lung tissue is not seen on ultrasound. So similar to, unlike kidney or liver, you cannot see lung as a tissue unless it is consolidated or atelectatic. All you see are artifacts. If you see horizontal lines called A lines, that's normal. Normal air-filled lung has these horizontal artifacts. That's good. If you see vertical sun ray-like artifacts, these are called B lines. They represent interlobular septal thickening, which is commonly because of fluid. It could be because of fibrosis also. That's why you have to interpret in the right clinical context, but commonly because of fluid. So if you go back to our patient here, you see all these sun rays, that's bad. So there is fluid all over the lungs. And these are sonographic images of A lines and B lines. So A lines, these are the horizontal lines, and the B lines are the vertical lines emerging from the pleural interface. This bright line here is the pleural interface. Okay, and we know that lung ultrasound is more sensitive than physical examination. That's proven beyond doubt. I mean, you're using an ultrasound probe that is sensitive than any physical examination that you can compare it with. But lung ultrasound was also shown to be more sensitive and specific than a chest X-ray to detect cardiogenic pulmonary edema. So sensitivity of ultrasound was 91.8 compared to 76.5 of chest X-ray, and specificity of 92.3 compared to 87%. So there is no reason to repeat chest X-rays in these patients and expose them to unnecessary radiation, even if it's mild radiation. So why should we do that when you can perform point of care ultrasound as a part of your physical examination? And how about pleural effusion? This is another thing we commonly want to look for, right? So pleural effusion, you put the transducer, say somewhere in the posterior axillary line, so somewhere in this area, in between the lung and the liver on the right side and lung and the spleen on the left side. So you put the probe here. Normally, like you see the liver here, observe this carefully. So this is the liver and this is the diaphragm. And on top of that, as the patient breathes, you see these nice horizontal lines, which is normal lung going over the liver. So that's how a normal, the junction between the lung and liver should look like. But if you have effusion is fluid is anechoic on ultrasound. So this is how it appears. So this is liver, this bright thing is the diaphragm, and all this thing is the pleural effusion. And in cirrhosis, there was a study with 116 patients with decompensated cirrhosis. And interestingly, anteroposterior chest X-ray, that's what we obtain in hospitalized patients, failed to recognize 40% of pleural effusions seen on lung POCUS. And pleural effusion on POCUS was associated with increased hospital length of stay as well as mortality. And as you know, I mean, there was a lot of data in hemodialysis patients showing the prognostic significance of lung ultrasound. Anyway, so that's the left-sided pressure spot. And coming to the inferior vena cava ultrasound. Inferior vena cava ultrasound is very familiar, if not the technique, at least most people have heard about this. And something, this is what essentially nephrology-related POCUS is, but it's not, especially not in cirrhosis. I'll tell you why. So inferior vena cava ultrasound, so this is the head end, this is the feet end. So basically it's a tube that's connected to the right atrium, right? So this tube here is the inferior vena cava, and this beating structure is the heart, and this thing more specifically is the right atrium. And you look at the diameter and collapsibility of inferior vena cava. So if this is a tube that goes to the right atrium, if the right atrial pressure is high, that means this tube is big. So a plethoric inferior vena cava increases elevated central venous pressure or elevated right atrial pressure. And a small collapsible IVC indicates not elevated right atrial pressure. Remember, it does not differentiate between hypovolemia and euvolemia. Never use IVC alone to distinguish between hypovolemic hyponatremia and euvolemic hyponatremia, because all it tells you is whether the right atrial pressure is elevated or not. And where do you measure IVC? So here is the hepatic vein. So just below the IVC hepatic vein junction, you measure the IVC diameter. And during inspiration that collapses, generally the collapse is more than 50%, because during inspiration there is more increased venous return and the heart is sucking the blood. Okay, so remember this picture and the concept. So we'll take you to the IVC study in cirrhosis. So there was this famous study, or probably the only study looking at the role of inferior vena cava ultrasound in cirrhosis in the context of evaluating hemodynamics. So they had this 53 cirrhotic patients who had clinical diagnosis of HRS type 1 with a mean serum creatinine of 3.2 milligram per deciliter and a MELD score of 29. In these people, they did inferior vena cava ultrasound, and they have classified these sonographic findings into these specific things. So the first one is a small IVC, less than 1.3 centimeter, and a collapsible IVC. The IVC is like small and collapsible. They said the patient is most likely volume depleted. I know I said that's not how IVC should be used, but that's what they did in the study. They found that 28% of the people who had clinical diagnosis of HRS had volume depletion or potential volume depletion. Because in HRS, you assume these patients are euvolemic and you already corrected hypovolemia. And the second scenario is IVC was more than 2 centimeters, that is a plethoric IVC, and collapsibility less than 40%. That means it's indicating elevated right atrial pressure. 21% of the patients had elevated right atrial pressure by that classification. That means that's also not HRS, so probably these patients had congestive nephropathy. And another subset of patients had small IVC, but that was not showing any respiratory variation. They concluded these patients most likely had intra-abdominal hypertension. So about 15% of the patients had intra-abdominal hypertension. So the point is, approximately 65% of the patients who were thought to have hepatorenal syndrome had alternative diagnosis just by using IVC ultrasound. But again, I'm not a fan of isolated IVC ultrasound. I do not recommend isolated IVC ultrasound because it has so many pitfalls. The first thing is IVC, when you look at that, I showed you the long axis image, right? So IVC is a three-dimensional structure. I don't know if you can see, but like say this is a three-dimensional structure here, and you have a two-dimensional ultrasound beam. So the beam could be slicing the IVC in its center or its periphery. If the beam is slicing in the periphery, then you get falsely low measurement of the diameter, as in this case. So this one will give you the falsely low diameter of the small diameter of the IVC. And that's especially problematic when you do the ultrasound, your attending comes and does, tomorrow somebody else does. It makes the readings non-reliable. So it's always a good idea to look at IVC in both long and short axis views. And we are talking so much about the IVC collapsibility, right? But all these collapsibilities have been validated in outpatients who are of reasonable health in the outpatient echocardiography laboratory. But inpatients are sick. Their strength of breath is really cannot be standardized, because in the same person, as the hospitalization progresses, depending upon whether they are getting worse or getting better, the strength of breath changes. And as you know, a 30-year-old muscular man's strength of breath is always different than a 80-year-old woman's strength of breath. So that's another problem. And say if you have conditions like chronic pulmonary hypertension, the inferior vena cava is always plethoric. Just because IVC is plethoric, you can't say volume removal is the answer. Maybe the patient needs pulmonary vasodilators and not a volume removal. So these are some technical pitfalls. I can give a whole lecture on IVC technical pitfalls, but we'll restrict to cirrhosis now. So in cirrhosis, there is like in majority of the cases, there is caudate lobe hypertrophy, right? So on the left, you have normal IVC here. This tube is the IVC. Here is the hepatic vein, nicely seen. Here you measure the diameter of the IVC. Okay, so that's good. And this thing here is the caudate lobe of the liver. So in cirrhosis, the caudate lobe gets bigger. So now what happens if the caudate lobe gets bigger? It's going to compress on the IVC, right? And in cirrhosis, all this fibrotic tissue is going to compress this hepatic vein. It's also very difficult to see hepatic vein in cirrhosis unless they are really enlarged. So this IVC becomes artificially of lower diameter, and that's called IVC scalloping. And actually, this finding was sensitive. Moderately sensitive and specific for the diagnosis of cirrhosis. So that means in a significant proportion of patients with cirrhosis, you'll see this IVC scalloping, which limits its utility to evaluate right atrial pressure. And that's one thing, the IVC getting smaller. And IVC can also get bigger in cirrhosis, even without elevated right atrial pressure. So in these examples here, like IVC is so big, right? But it does not mean this patient had elevated right atrial pressure. IVC can get big in cirrhosis because there is a lot of veno-venous shunts and collateral circulation. So IVC is receiving more blood than usual because of the portosystemic connections, and that can make it chronically big. So that's one problem with that's another problem. So if IVC is small, you can't trust. If IVC is big, you can't trust. And what about this? This is a real life image obtained from a patient with cirrhosis. So here is the IVC here. This is the liver, and this is ascites. So now tell me, where should I measure the diameter of the IVC? I mean, I don't see any hepatic vein here. Maybe it's somewhere here. I don't know. Like if I assume the hepatic vein is here, should I measure the diameter here? Here I don't see any vessel opening. Should I mark diameter as 0 or 0.1 centimeters? So I don't know. So in real life, this is what you would see. Though it's not as easy as looking that study and thinking IVC is great at differentiating etiologies of AKI. How about these? These two images, the nephrology fellow has marked these vessels as inferior vena cava here. So is the fellow correct? Probably not, because this vessel seems to be like pretty posterior and going towards the thorax. And here also it's passing beyond the diaphragm and going into the thorax. This vessel is actually aorta. It's very common to mistake aorta for inferior vena cava, especially when the IVC is small. So in these images, actually the IVC is here and here. You call that like sliver in the liver appearance of IVC. It's very small IVC. It could be potentially because of increased intra-abdominal pressure also. So, but the point is, like, even experienced users on hurry-burry examinations, they can mistake aorta for IVC. And sometimes it's impossible to find IVC. These two examples here, I tried for like 5-10 minutes. I couldn't find IVC. I did like probably over 1,000 IVC scans so far, and or more than that. But the point is, like, even for experienced operators, you might not be able to find inferior vena cava in cirrhosis because of local structural alterations. So is there an alternative to IVC? So we bashed IVC. So yeah, I mean, how do you traditionally measure central venous pressure or right atrial pressure when you don't have ultrasound? You look at JVP, right? So internal jugular vein essentially goes into the right atrium. So similar to IVC, it also reflects the right atrial pressure. And this is a traditional method. So you examine the patient's venous pulsations and you figure out where the highest point of venous pulsations is. And from there, you measure its height from the sternal angle and add 5 centimeters to that, assuming right atrial depth is 5 centimeters. This is great. I mean, it's a time-tested method. We all learned it in medical school, but what's the problem? I mean, in a substantial proportion of patients, you cannot find venous pulsations, or you can mistake arterial pulsations for venous pulsations. And sometimes depending upon the patient's skin color also, that also sometimes impedes visualization of the vein. And not only that, this 5 centimeters has shown to be pretty unreliable number, because the right atrial depth varies considerably in patients. So ideally, you have to measure the right atrial depth using point-of-care ultrasound to properly calculate the right atrial pressure. Anyways, so at least qualitatively, how do you use ultrasound to estimate right atrial pressure? Using IJ vein ultrasound. Okay, so on the left here, you have a transverse view of internal jugular vein. So this is the thyroid gland. So this is my probe position, right? So this on the medial aspect is the thyroid gland. Here you have the carotid artery, nice and round. Here is the IJ vein. So usually IJ vein is pretty collapsible, and it's a oval or triangular in shape. And this is a long axis view of the internal jugular vein. So you see a nice paintbrush type of architecture here. And wherever this vessel is collapsing, or the tip of the paintbrush is the highest point of venous pulsations that you would see on inspection method. So that's how you can use internal jugular vein ultrasound to estimate right atrial pressure. It's so hard to get this nice long axis view. In normal people, you can, in volunteers, but in patients, it becomes hard, because as the probe slightly moves, you will lose this image. So it's more reliable to just look at it in short axis and just trace it upwards. So like cut it here, cut it here, cut it here, and go till the short axis view of the internal jugular vein becomes small. So this is how you do it. You put the transducer here, and you just tracing upwards till you find the collapse point. So here is the carotid. This is the internal jugular vein here. Observe carefully. It's becoming small at one point, right? So that's where is the collapse point of internal jugular vein. And how about this patient here? So how is the right atrial pressure? How would you estimate? So I'm tracing it upwards. See from now. So this is the IJ vein. It's pretty big. And I see the carotid bifurcation here. And then it collapsed beyond carotid bifurcation. In this anatomic image, you see carotid bifurcation somewhere here, like in the maybe in the upper 50% of the neck. And beyond that, the IJ is collapsing. Maybe the collapse point is somewhere here, indicating elevated right atrial pressure. Or actually, it's not really here. In this patient, I think I was able to trace it up to angle of the jaw for it to collapse. So it was pretty high. And in one study, that's one method of doing it, right? So you trace it upwards and look for the collapse point. Other way is asking the patient to perform a Valsalva maneuver. When you do Valsalva, right atrial pressure increases, and the internal jugular vein becomes big. So if the internal jugular vein does not get big with Valsalva, that means it doesn't have much space, or the right atrial pressure is elevated. So in one study, less than 17% increase in right IJ vein surface area with Valsalva predicted elevated right atrial pressure with pretty good sensitivity and specificity. If the patient is cooperative and able to do Valsalva, that's a good idea. And in a recent study looking at internal jugular vein point-of-care ultrasound in cirrhosis, they found that IJ POCUS had better correlation with right atrial pressure and area under the curve compared to inferior vena cava. Not only that, IVC images were unobtainable in close to 20% of the cases, consistent with our real-life experience. So IJ vein is something to consider when your inferior vena cava is unreliable or unobtainable. And also, IVC is not very reliable in intra-abdominal hypertension, right? So because there is a lot of ascites and bowel edema that's compressing on the vessel, so you cannot rely on the diameter. And in one study that included surgical patients who were undergoing laparoscopy, so they inflated this peritoneum. In spontaneously breathing to positive pressure ventilation, the IVC got slightly big as expected. But when the intra-abdominal pressure was increased to 15 millimeters mercury, then IVC size has actually gotten small. On the other hand, internal jugular vein diameter did not get small with increased abdominal pressure. So you can use that as a fairly accurate guide to estimate right atrial pressure in patients with increased intra-abdominal pressure. So let's see a couple of cases where we used both inferior vena cava and internal jugular vein. So on the left, you see an inferior vena cava from a patient with cirrhosis. So this is the liver, this is the ascites. Here is the IVC. So where do you measure the collapsibility? Now, I don't see any hepatic vein. It's very hard to see, but anatomically, I would assume it's somewhere here. So technically, I should measure the IVC collapsibility and diameter here. Then I would say maybe 0.2 centimeters and it's 100% collapsible, right? But how about here? It's not really collapsing. And we said that there is caudate lobe hypertrophy in cirrhosis. So how much can I trust that? So I looked at the internal jugular vein. And see this? As we trace upwards, it's collapsing beyond the carotid bifurcation. So this patient had elevated right atrial pressure. So giving albumin is not a good thing for this patient. How about this image here? It's very difficult. I mean, cirrhosis patients are very difficult to image, so you have to pay close attention. So this is the liver. So it's very shaggy borders, and this is the ascites here, and here you see the lung. So this thing here is the inferior vena cava. It appears big, but when I did the internal jugular vein ultrasound, asked the patient to perform a Valsalva, see what happens. So this is the carotid. IJ vein initially it's like a slit, and as the patient does Valsalva, see how big it becomes. So the right atrial pressure is definitely not elevated, and this patient should not be given diuretics. And once you have elevated right atrial pressure, you can also use Doppler techniques to evaluate the systemic consequences of elevated right atrial pressure. That is, if this elevated right atrial pressure is altering the blood flow at the organ level, that's called VEXUS or venous excess ultrasound. That's my favorite topic, where you would do Doppler of hepatic vein, portal vein, and intrarenal vein. But I'm not going to talk about it. I'm just mentioning it because that itself is a whole different lecture. And VEXUS has some limitations in the context of cirrhosis because the local structural alteration might affect how we interpret hepatic and portal veins. But intrarenal venous flow evaluation is still reliable. Okay, here we have another patient with cirrhosis who is seen for AKI, has been getting the cocktail, and the patient does not have any shortness of breath, and physical examination reveals this. So what are we looking at? First, let's go from easy to slightly difficult. So on the right, you see lung ultrasound, and you see these horizontal lines, right? So that means there is no fluid in the lung. That's good. No congestion. And in the middle, you have inferior vena cava. There is pretty good collapsibility of inferior vena cava, and there isn't much ascites here. So IVC is small and collapsible. So you can say that the right atrial pressure is not elevated. Fine. But how about the heart? So here is a short axis view of the heart. So this is the left ventricle, this is the right ventricle, and this is pretty normal appearance. But the heart, the left ventricle seems to be squeezing pretty vigorously. So consistent with some hyperdynamic heart, right? The ejection fraction would be definitely more than 65 or something like that. So do these findings warrant fluid administration in this patient? Are these findings consistent with volume depletion? That's another question. So you perform multi-organ ultrasound, but how do you interpret changes, right? And remember, we said like a lot of patients with cirrhosis have hyperdynamic circulation. So you also want to look at the stroke volume. And if the stroke volume is high, say if the stroke volume is high and the cardiac output is 8 liters, right? What's the point of giving a crystalloid or colloid? So it's essentially useless and ultimately predisposes to having fluid overloaded once a patient is transferred to ICU and gets norepinephrine or terlipressin. So you shouldn't be doing that unless you believe in pleiotropic effects of albumin. I don't think anybody believes that. I'm not sure. But anyways, the point is albumin is probably not a good idea if you have increased cardiac output. On the other hand, with the same findings, you can have volume depletion. And if the stroke volume is low, that is consistent with volume depletion. So the patient would benefit from fluids. So for that, you do a Doppler assessment of the left ventricular outflow tract. I'm not going to go into detail. So basically, this is the blood flowing out of the heart with every beat. And if you trace that, you get a number called VTI, or velocity time integral. Normally, it's about 18 to 22 centimeters. That you can take it as a surrogate for stroke volume. So if it is 18 to 22 centimeters, that's normal stroke volume. In this case, it's close to 28 centimeters. So it's elevated. So in this patient, the calculated cardiac output with the stroke volume and everything was about 8 liters. So we did not give fluids to this patient and recommended early initiation of vasopressor. The teaching point is hyperdynamic heart is not equal to volume depletion. It could very well be high output cardiac state in a case of sympathetic stimulation. And liver failure as a cause of high output heart failure has been under recognized. In this very well done, like a long-term study from a single center, liver disease constituted 23% of the cases of high output cardiac failure. So it's very important to recognize that. We have another patient here with cirrhosis who is seen for AKI. Diuretics were put on hold as usual. As you see, patient with AKI, people tend to give fluids, people tend to stop diuretics and so on. So his IVC was not well visualized, had a neck collar. So we still can perform physical examination, that is POCUS, right? So you look at the heart, and remember this is the same image, same cut of the heart like we saw in the previous image. So left ventricle and right ventricle. Normally the left ventricle is nice and circular, but when the right ventricle is enlarged, it compresses on the interventricular septum, making it flattened. So the ventricle becomes like a D. That means there is right ventricular size increase, commonly due to fluid overload, which can also be due to hemodynamically significant pulmonary embolism, but in our context, mostly fluid overload. So this patient was deemed hypervolemic, and we put this patient on continuous renal replacement therapy. And after a few liters removal, you can see that nicely the left ventricle has become round again. So basically, POCUS will allow you to visualize physiology at the bedside. You don't need to think too much. It reduces your cognitive burden. Last case or last point. So a patient with cirrhosis is seen for acute kidney injury. IJ vein was not suggestive of elevated right atrial pressure, but lungs did show bilateral B lines. This is also like a fluid intolerance, right? So just because somebody's CVP is not elevated, it does not mean there is an indication for fluid administration. Just in generalized high output cardiac state without high output cardiac failure, you can still have normal right atrial pressure, but the lungs do show bilateral B lines. Probably this patient had elevated left ventricular filling pressures. Having said that, B lines are not specific for pulmonary edema. Remember, we said B lines indicate thickened interlobular septae in the lung, and they can be engorged because of fluid, and that fluid could be coming from the heart as in cardiogenic pulmonary edema, or it could be pneumogenic as in ARDS or infectious etiology. Patient could have COVID-19 or even fibrosis. So how do I know these B lines are indicating only cardiogenic pulmonary edema and I should give diuretics to this patient? It's hard. There are some clues in the lung, but it always helps if you know a little bit of Doppler echocardiography. So this is the left side of the heart, this is left ventricle, this is left atrium. So if you're able to assess the flow pattern through the mitral valve, you can assess the filling pressures non-invasively at the bedside. Without going deeper into the details, I would just stop there saying that having some knowledge of Doppler echocardiography always helps. Or even if you don't do it, like you should be at least able to make sense of numbers that are given to you in the echocardiography report. So basically, multi-organ point of care helps immensely in the evaluation of acute kidney injury in cirrhosis. And this is my standard slide. So like this machine has no brain, so use your own. So point of care ultrasound gives you findings, and how much good that would do to the patient entirely depends upon your clinical integration rather than your skill of acquiring the images or interpreting them alone. And I recommend these articles if you're further interested in reading about it, or if you want to get a summary of what we spoke today. This Kidney 360 perspective published in 2022. So cirrhosis-associated AKI beyond inferior vena cava, this nicely summarizes that. And this article by Dr. Kazori and me in heart, it is written in the context of heart failure, but this is a very comprehensive review on how to use multi-organ POCUS in evaluation of congestion. So I recommend these articles. So thank you so much, and it's a pleasure to be here as always. Thank you.
Thank you so very much, Dr. Koratala. As always, it was amazing. The images, the thoughts, the controversial themes that you touched on, that was excellent. I just want to remind everyone that Dr. Koratala, I learned it from him, that people say, oh, this is operator dependent, the ultrasound, be careful with it and all those. On the flip side of what he showed about the brain, you also should remember also your physical exam is also operator dependent. So it is nothing different from what your auscultation, which is operator dependent. So that was excellent. Abhilash, I wanted to just first of all to repeat what you said, which is important, that we always hear hepatorenal syndrome, start albumin regardless. So your POCUS basically is telling us some of these patients you don't need to start, and this is what actually Dr. Mitra Nadim, who wrote that review paper in NEJM, has been always emphasizing in her talks, and actually she will be in your session on Thursday afternoon, I guess, at the ASN, and I'm sure that she will mention it again. This is an important point. In the interest of time, I just want to ask you one simple thing that I think I missed. When you were showing the bifurcation of carotid, and you were saying that it is beyond that, you meant that when it is beyond bifurcation, we have higher volume. Is that what, or something else you wanted to mention?
That's right. So basically, I was trying to say, ultrasound evaluation of IJ is like a visual inspection of pulsations, right? You want to know where is the highest point of the meniscus, that's like a manometer to the right atrium. So if that collapse point of internal jugular vein is beyond the carotid bifurcation, it's already higher. It's somewhere here in the neck.
Yeah.
So yeah, that's what I meant. Like it's probably like close
this
to the
was
angle
amazing.
of the jaw.
The ruler that you showed and all those from NEJM, it just remind us how far we have come with POCUS. Actually, that was really eye-opening. Thank you very much. It's 1 o'clock, so those who need to leave, they have clinics and all those, they are more than welcome to leave. If there are people that have questions for Dr. Koratala, I know that we don't see him very often, so I want to leave the stage open in case there are questions. Okay, or probably not, because you have been very clear. Abhilash, thanks again, and I look forward to seeing you next week in Philadelphia.
Thank you so much. Same here. Nice meeting everyone.
Have a great
Thank you.
rest of the day.
Bye.
Bye.